Hello, Dr. Tsakos. Welcome back. All good, I hope.
Hi. Good evening, everyone. Yeah, everything is fine. Thank you so much. And thank you for the opportunity to present a controversial subject, which I hope I will shed some light for our patients.
Definitely. I'm really looking forward to the Q&A session. But of course, first we will start with the presentation, which will take up approximately 30 minutes. And afterwards, there will be time for your questions. So please remember to put the questions in the chat. It's all anonymous, and Dr. Tsakos simply will answer all of those. Maybe not all of those, sorry. We will try to answer as many questions as possible. We have 1 hour for this, so I'm sure it's going to be a great session indeed. And before we start, let me just remind everyone that this is being recorded, and you will have a chance to rewatch this once again. And I think we can start with our presentation. You can type the questions right now during the presentation and also afterwards, of course. And let me just show you the presentation, and let's start.
Right, okay. Right, so good evening again. This is a very controversial issue. This is because of the fact that commonly these days, one of the challenges we're faced with are including poor ovarian reserve, advanced female age, and generally the ovarian aspect, the oocyte aspect of IVF, which means that we're dealing more often these days, and definitely in the last 5 to 10 years, we're faced with women of advanced reproductive age, women over the age of 35, commonly, sometimes over the age of 40, even women over the age of 45. So one of our main concerns has always been the quantity and the quality of the oocytes. We know only too well that women are born with a certain number of oocytes, and this number is exhausted, unfortunately, begins to diminish very early. How early is that? Possibly in the late 20s, early 30s, the diminishing of the oocyte reserve begins. And this demise is much more pronounced after the age of 35, and the decline is more rapid, and it's even more rapid after the age of 40. So we've been very concerned about that. So only in the last 15 years, we've tried to develop some markers of ovarian reserve. And of course, you may all be very familiar with the most popular and perhaps the most valuable marker of ovarian reserve, which is the AMH. The AMH, together with the anti-Mullerian hormone, together with the antral follicle count, which is the measurement of certain numbers of certain sizes of follicles in the ovary, are trying to give us a prediction of the ovarian reserve. And in actual fact, my team and I, we've been amongst the first people, I believe, who studied that. We studied in the late 2010, 2009, 2010. We studied the value of AMH, and we compared in predicting ovarian response, and we've actually compared that with original studies, original research, with the standard at the time, which was the FSH Elias Tsakos baseline measurement, together with the antral follicle count. And actually, we produced a couple of scientific papers which have been included in the European Society of Human Reproduction and the ESHRE guidelines for ovarian stimulation. So my team and I have always been very sensitive with regards to identifying, if you like, the ovarian reserve and markers for ovarian reserve in predicting ovarian response to stimulation. Having said that, in my opinion, and you may write that down, in my humble opinion, the best marker of ovarian reserve is the previous effect of stimulation or the previous yield on success on optimum ovarian stimulation. So no matter how much we try to pinpoint the ovarian reserve and we try to predict the ovarian response to stimulation, unless a patient, a female patient, is undergoing ovarian stimulation, effective ovarian stimulation, because sometimes ovarian stimulation may not be effective, may not be optimal, may not be managed 100% correctly. And this is the absolute indication, in my opinion, of ovarian reserve. Now, why am I giving you this introduction? Because because I want to put a personal note here for whatever value this may have. Although we've been quite, we pioneered quite interestingly the AMH introduction into the clinical practice. I have personally been my team and I have been very reserved with regards to measures and methods of improving the ovarian reserve. And so coming up to the subject tonight, although PRP rejuvenation, which I'm not sure I like this term, or PRP injection, PRP attempt, if you like, to kickstart the ovaries and produce more eggs, has been around for about 15 years. My team and I would have not scientifically been fully convinced yet, and therefore we're just very guarded with regards to its effect. So this is a little summary of the presentation. However, the evidence is accumulating. PRP effect obviously on other organs has been widely used in clinical practice, like orthopedics, like aesthetic and plastic surgery, like rejuvenation of the vagina. However, with regards to reproduction, the PRP effect, which may be involving endometrium and ovaries, the evidence for that has only been emerging really in the last few years. So although there is enough evidence, in my opinion, perhaps to allow us to use platelet-rich plasma for endometrial factors, which was the subject of a previous webinar. So I'm pretty convinced there is science there is evidence, for some certain cases in which PRP endometrial treatment may be effective. With regards to PRP on the ovaries, although there is some evidence, I don't think the evidence at the moment is solid enough for universal clinical application. So this is my take-home message even before we start. So let's look at some data. So introduction to ovarian PRP, how is it produced, how does it work, what is the evidence, and what are the future prospects? So this is more or less what ovarian PRP looks like. What is it? It's platelet, the initials for platelet. It's the acronym for platelet-rich plasma. It's an autologous product, so it's our own product from our own body fluids, derived from peripheral blood. We prepare this with centrifugation. There's no extra medications usually added, although there are some protocols in which we may fortify this medium with additives. It's a very simple delivery. Very simple for the endometrium, in my opinion, not so simple for the ovaries, because we need to inject this into the ovaries. There's a very low incidence of allergies or adverse effects, and it has been used for many years in medical specialties, which is important in terms of safety. However, I'm not sure how important it is in terms of effectiveness, because the way various organs respond may be variable. So what is the principle? The principle is that we make this product and then we inject it into the ovaries, either via transvaginal injection, similar to the oocyte pickup, or through laparoscopy. How do we choose the method? Basically, it's based on the visibility of the ovaries, on the test we do beforehand with regards to how accessible the ovaries are. So if they are safely accessible vaginally, then yes, the vaginal route is the simplest way to do it. But if they're not, if the ovaries are pushed away from the pelvis, from the inner pelvis, or if there's adhesions involved, if there's bowel interfering between the vagina and the ovaries, then perhaps the abdominal, the laparoscopic route may be more appropriate. So the route of injection depends on the characteristics of each patient. And here we can see the transabdominal route. To be honest, depends on who you ask. One of the problems that I do mention many times is that nowadays most fertility specialists, the young fertility specialists, they're not very familiar with laparoscopy and so forth. So they would probably have to associate with laparoscopic surgeons in order to perform this technique. And also laparoscopic approach may not be able to be safely performed within the premises of an IVF unit, and it needs like specialized theater. So this is another issue. In my opinion, I think it's very important to decide the route. And in my practice, in our practice, where we do have familiarity with endoscopic surgery, to be honest, we feel much more secure, much safer, and much more complete, if you like, if we perform it laparoscopically. And if not, then we need to add that laparoscopy, apart from the treatment procedure, also provides very good diagnostic procedures. So this is something we weigh, and of course we individualize depending on our patients. So, for example, if a patient has had a laparoscopy recently, we have excluded endometriosis, pelvic infection, hydrosalpinges, any anomaly in the abdomen recently within the last 2 to 3 years, and the ovaries are accessible via the vaginal route, then of course we prefer the vaginal route. However, otherwise, personally, I have very low threshold in suggesting at least laparoscopy, not only for the ovarian PRP introduction, but also for diagnostic purposes. And in order to be more complete in my pelvic assessment in a fertility patient in whom I know only too well that the chance of having endometriosis, which may be undiagnosed, can be 3 to 5 times higher than the average population. So the timing, again, one of the challenges with new techniques is that they haven't been standardized. So you have some pioneers, and there's some amazing people around the world who have pioneered various techniques, including this one. But they all do their own thing, if you like. So it's not standardized. So it's not fully standardized when is the best time to do it. So we all try to use a little bit of our common sense. And we all try to perhaps minimize the trauma, the trouble, and the additional procedures to our patients. So, in my opinion, although the random procedure is perhaps the most popular one, but to be honest, sometimes I do favor PRP during the ovarian pickup on a low response patient. If I have a 38-year-old with low response with 1 or 2 follicles, and of course I have counseled and explained to her beforehand, I like to use the same procedure, the same anesthetic once I've aspirated the follicles to inject PRP as well. I mean, obviously this treatment is not going to have an effect until the next or the 2 months later down the line, but it saves me, if you like, a second procedure for that. And again, some people perform it in the first half of the cycle. It may be challenging, it's at least, especially vaginally, because we're talking about patients with very small ovaries, with very little, if any, follicles. So it's a very small target to aim for. So it requires a lot of skill, in my opinion, and a lot of luck in terms of the ovaries being in the right place to be punctured. So how do we produce the PRP? This is pretty straightforward. We withdraw blood. Again, various protocols. To be honest, I like to withdraw a little bit more blood than average, so perhaps 30, 40 mils sometimes in our practice. I mean, I'm very grateful to my amazing lab team. We perform PRP in-house for many reasons. Main reason is that we have standardized procedures within the lab, within aseptic environment, if you like, to ensure that the whole technique is free of contamination. And also, of course, we have standardized methods of separating and centrifuging the blood into steps and so forth. So it's a fairly straightforward procedure. So the patient comes in the morning, and then depending on the protocol, within a couple of hours, maximum, we have the, sometimes a little bit longer, we have the PRP fluid ready. So 30 to 40 mL of peripheral blood. The blood undergoes a long centrifugation in specialized tubes. I was tempted to give you some more specialized figures, but following discussions, because this is very variable and we haven't really published results yet, so I omitted that. We separate plasma into plasma and red cells, and then ultimately 1.5 to 2 microliters of PRP is produced, and the overall concentration of platelets is very near 1 million, which is 4 to 5 times the concentration of the peripheral blood. So how does it work? How does it work? The power of the humble platelet. That's a very inspired title, in my opinion. So the platelets do have all those substances, antimicrobial peptides, multiple growth factors, and cytokines, which are very useful proteins. And we know only too well that in the event of any human injury, those proteins, they promote proliferation, healing, neoangiogenesis, which is a fancy Greek word to describe the production of new vessels, new blood vessels, which are absolutely essential for new tissue to be formed. And of course, there's a mechanism of immune modulation, which also has been studied and seems to play a fairly significant part. So improved blood supply. So what's the outcome? The outcome is improved blood supply through the creation of new blood vessels, improved blood flow. So this is the better ability to deliver all the, either drugs or nutrients or antioxidants to the ovary. And the whole theory behind that is that basically by improving the flow, we improve the delivery of good stuff on the ovaries. And of course, there's improved follicular environment, if you like, milieu, which is through cell proliferation, through upregulation of granulosa cells and receptors, and through reactivation of follicular development. So the theory is there. I mean, there's good theory behind it, for sure. But what is the evidence? Now, my team and I, and I'm very grateful to the research team and a very experienced senior research fellow, Dr. Manos Xidias, who collected the data. There is some nice evidence. Here we can see a meta-analysis, recent meta-analysis on pregnancy and childbirth, which favors the use of PRP with regards to increase of AMH. So we have an increased marker of ovarian reserve. We have more antral follicles. As I mentioned in my introduction, AMH and antral follicle count are probably today the best predictor markers of ovarian reserve. So there is good evidence that they improve that. And also in the number of collected oocytes. So that was a very good meta-analysis published this year in a good journal. So another advantageous effect is that there's few cycle cancellations. In my opinion, this is important as well, because we know only too well in our units that, every day, every month, every week, we have a lot of patients in whom we canceled the treatment because of poor ovarian reserve. So reducing cycle cancellations by 65% is a very promising effect of ovarian PRP. And we even have increase of cleavage stage embryos. I mean, here the research, which is embryos before they get to the stage of blastocyst. Of course, we're concerned that, we don't know what happens if we grow them to blastocysts, but, there's good evidence that we have more embryos. And in theory and in practice, we see that, we know that more embryos generally more babies. So there is some evidence there. Of course, as I said, the evidence is not overwhelming. It's not, 100% there. There's a lot of questions unanswered. Which patient, how old, Is there a cutoff in the age? Is there a cutoff in the AMH under which it doesn't work? Is there a cutoff in the AFC? I mean, can we use this just for poor ovarian response, or can we use it for no ovarian function whatsoever? What type of investigation we do before that? I mean, how far do we go? I mean, okay, we look into genetics, in my opinion, for sure. But I mean, do we look into other factors like, for example, like resistance of receptors on the ovaries, resistance to FSH stimulation and all that. So, it's not standardized. I think we have a long way to go before we have clear set guidelines of the subgroups of patients that may be beneficial. I'm pretty sure there's a subgroup of patients, to be honest. I don't really know which ones are they going to be. My feeling is that the greatest benefit is probably for younger patients, which is patients under the age of 42, 43, with poor ovarian reserve, with poor response to stimulation, maybe with previous history of surgery on the ovaries, but generally, in order to improve the healing. I don't know about endometriosis. I don't want to touch upon that, which we all know affects the ovaries. But I think, yeah, definitely the younger patients may benefit, may be worth having a go. Of course, following careful consultations, careful counseling, and informed consent. The younger patients in whom we have excluded important factors of poor ovarian reserve, like DNA anomalies, like receptor anomalies, and so forth. And perhaps the patients in whom we do have a little bit of ovarian reserve, we have at least one or two, maybe young follicles on each ovary, perhaps. But this remains to be seen. So, does it create neurocytes? I don't know. We don't know. We don't really know. It's controversial. It's experimental. Some studies have questioned the theory. Some other studies perhaps showed that it may stimulate cell differentiation. So I don't really know. The research is ongoing. There's a very good paper, fairly recent, within the last 2 years, addressing this subject. I think until now the evidence is more towards the recruitment of more follicles rather than creating young oocytes, but this remains a controversial issue. Now, in contrast with the ovarian PRP, which is not fully researched or standardized or evidenced at the moment, however, in my opinion, there is a limited place perhaps for the younger patient, and maybe combined with a laparoscopy if a laparoscopy has not been done before, in order to exclude common factors of infertility and poor ovarian reserve, like endometriosis and pelvic infection. So the endometrial PRP, I'm pretty convinced at the moment that there is a place. So you can scan this QR code. Recently, we had a webinar with this subject, and my team and I, we have summarized that we have reviewed the evidence, and we feel that there is a place for endometrial PRP, especially for patients with a history of uterine surgery, history of endometrial adhesions, history of repeated implantation failures, and also patients with very poor endometrial response to priming for embryo transfer, and patients with repeated miscarriages. So we feel there is a place for those patients for endometrial PRP, but of course that's a totally different area, totally different subject. So take-home message with regards to ovarian PRP is that PRP, platelet-rich plasma, is an autologous product, blood product that has been safely and successfully applied in many medical fields, including fertility. That PRP in general induces cell proliferation, multiplication, and improves the vascularization and blood flow in various organs, including the ovary, when it's injected into the ovary. The procedure is fairly, I wouldn't call it very simple. It's fairly simple, flexible, and can be combined with other procedures like the egg collection or diagnostic laparoscopy in order to reduce the costs for the patients and to reduce the trauma and the exposure to additional anesthetic and surgery. And the reproductive outcomes at the moment have been fairly impressive with the recent study, the recent meta-analysis. This has not been reflected on the pregnancy rate, perhaps because of the small sample, perhaps because of difficult patients. We haven't really examined the sperm factor and so forth. So, the fact that it hasn't been proven with increased pregnancy rates, in my opinion, does not negate the positive effect on increasing the follicle count, increasing the retrieved oocytes, and increasing the fertilization rates that we have seen on the ovary. And I think this is a very good start, very good base for more research on this subject. Some references, you're very welcome to take screenshots of that and look them up for yourselves. And a very, very warm thank you to my team on various reasons. One is that all of them, they're backing up the research and development department. So they work very hard with our patients on a day-to-day basis, so that the few of us on the research team, we work on preparing the presentations and preparing all those meetings, which is an amazing opportunity for all of us to exchange knowledge. Special thanks to this young guy here, this young chap, Dr. Manos Xidias. Write down his name. He's probably the next generation of world-class fertility specialists, and of course the rest of my team. Thank you all for listening, and I'm very, very happy to take some questions and hopefully shed some light for your particular case. Thank you.
Brilliant as always. Thank you so much indeed for walking us through the aspects of PRP. And of course, as you are right, we are now going to answer your questions. So there are some questions here. If you have more questions, you know what to do. Just type those in the chat so that Dr. Tsakos can simply answer them for you. And let's get going. This is a great topic indeed. And let me just start with the first question we have here. From Yelena here. So what results can patients typically expect from after the treatment? How often does the treatment need to be repeated, and how long does it take to see the effects of PRP?
Sorry, you're going to have to repeat this because you broke up a little bit.
Yeah, I can show it to you as well.
I can see it. What results can people expect? How often do we? Yeah, okay. Thank you, Yelena. I mean, it depends on the patient. I'm very guarded. I have to say that I'm very guarded with regards to the results, because, as I mentioned, I think that we don't really know yet the subgroup of patient who is going to be seriously helped, seriously assisted with this technique. We don't know that. And we have no means of identifying the subgroup of patients. My personal opinion, and in my experience of the last 35 years with couples with fertility, is that I don't think it's suitable for patients over the age of a certain age. Perhaps perhaps 43, in my opinion, is the cutoff level. So, and why is that? Because my feeling is that after this particular age group, it's the quality also seriously diminished. Both the quality of the oocyte, but also the ability of the oocyte to create healthy embryos free of chromosomal anomalies. So I would be very skeptical. I would double counsel and double consult and treble consult our patients over that age limit personally. The evidence is not strong. However, I would not like to do unnecessary treatments on patients where the hope is single figures. in creating a good quality embryo overall. And I would like to ring a bell of caution here, because we don't want to flag PRP as the miracle treatment, and we don't want the health authorities and the governments to ban it, if you like, as more or less as what happened with PGTA, which is a brilliant technique, but because it was widely used on everyone, and it was adding immense costs and trouble to a lot of patients. Some governments, including the health authorities of Greece, they more or less banned it. So they didn't. It's not free to perform PGTA unless you have very clear indications. So I would like to ring a bell of caution here to the patients, but also to our colleagues. Let's not repeat the same mistakes we did with PGTA. And let's be very selective and very careful in whom we suggest PRP for, especially for fertility. It's a different indication if you have maybe a 47-year-old who would like to prolong maybe her periods for a while, but not seeking fertility. And it's a different ballgame if we want to inject PRP on the ovary that we wish for the production of a competent oocyte, competent enough to produce healthy embryos. So in my opinion, not 43, 42 and a half, 43 is the absolute maximum. And then we need to assess the individual patient. I believe the best candidate would be someone in the perhaps mid to late 30s who produce maybe one or two oocytes and one or no embryos following effective stimulation, and in whom we have excluded additional comorbidity with genetic disease or infections.
Thank you so much indeed for your question, Elena, and of course for answering this question, Dr. Tsakos. Okay, let's have a look. So you've mentioned it might be more suitable for younger patients, and the question is, so how young? You've mentioned, upper age limit 43. So how about that?
Sure.
Other part?
Today we had a very interesting meeting. I mean, we have a meeting at Embryoclinic every day. When we set up those meetings, I had a lot of voices telling me, most of them inner voices, how long am I going to hold it for? How long am I going to allow? Most units, they have a unit meeting at best once a week. Some units perhaps a couple of times a month. So when I set up the standard of having a meeting, scientific and business meeting every single day, it's not very long. It's about 3/4 of an hour, 45 minutes. So in the meeting today, I mentioned an amazing patient in her 43s who is now pregnant, underway. She's on the 12th week, 13th week of pregnancy, everything healthy. She just phoned me up with a very good result on the 11-week scan and all that. And I repeated, and of course we have a lot of patients, and she achieved the pregnancy with one egg. We kept trying and trying with one egg, with natural cycles, with very little medication, tablets, Femara, clomiphene cycles, and so forth. And she made it. And of course, the same applies for the younger patient. I mean, don't forget that. So why am I saying this? I can see someone 32 who's collected 2 eggs and made 1 embryo. Don't give up. And actually, we have a wonderful young patient, 32-year-old, from a neighboring country with multiple ovarian surgeries, and she only produced 1 egg. So I told them at the meeting, and you're very welcome to ask me, 6 months down the line, what happened with that patient. And I said to them, keep it in mind, guys. She's going to get pregnant. Keep trying, keep going. Natural cycles, mild stimulation cycles, one egg, 2 eggs. She will get pregnant. The child, if we manage to keep her on the game, to keep her trying, to keep motivating her, to keep encouraging her, to keep assisting her with lots of ways, even financially. If we bring her prices down, if we give her a very good opportunity financially to keep going, she will get pregnant. So this is again another take-home message. If a 32-year-old is producing 1 or 2 eggs, she will get pregnant, in my opinion, perhaps without the need of PRP. So I'd rather do, 2 or 3 more natural cycles than use PRP, to be honest, on a 32-year-old who's producing eggs, who's producing reasonable quality eggs that make at least one embryo.
Okay, thank you so much. And we can go to this question. Actually, you've seen it, and I will display it here. So this is actually the question. So I am 32, 2 previous failed IVFs, 2 eggs collected in each cycle, 1 fertilized and transfer on day 3. AMH 6.7 picomoles. Would I be a good candidate for PRP?
Sure. I mean, let me give you some encouragement here. I mean, firstly, I challenge you. Next year, you're going to be pregnant. If you keep trying, please find us and send us thank you when it's been done, because I'm sure it will happen. So that's my first piece of encouragement. The second piece of encouragement is that with an AMH of 6.7 picomoles, I would probably expect a little bit more eggs. So please ask at your age. So please discuss with your doctors, perhaps the change of a protocol or using a different protocol. Sometimes flogging you with massive doses perhaps may not be the trick. It's like treating your children. I mean, sometimes if you're too strict, they do exactly the opposite. Sometimes we have to be mild, and the ovaries come to us, the eggs come to us without much effort. So my second piece of advice would be try a different protocol. Perhaps try something milder in order to identify the right protocol. Number 3, try for blastocyst. It would be important to see if your embryo is going as far as blastocyst, because in my opinion, fine, it makes no huge difference between top quality day 3 and the blastocyst in a young patient for first, second, third time of IVF maybe. But then when it gets a little bit harder, I think it's important to see the potency of that embryo by culturing a little bit more. So in every cycle, try to do something a little bit different, but something with logic. Yeah, sometimes we stimulate too much and we burn the follicles. Sometimes maybe we initiate the antagonist too soon or too late. So I have an amazing friend in England. He's always watching those webinars. He's my best friend in England, Dave Gibbon, who happens to be amongst the most experienced embryologists around, who, as doctors, as fertility doctors, we always think that, 99% of the success is the embryologist, but it seems that some of our embryologists, they think that 99% is the stimulation. So I think it's somewhere in the middle. So, stimulation is not as easy, ovarian stimulation is not as easy as it sounds or as it is made out to be. It requires a little bit of attention. There are some amazing people around who have amazing results, who scan ladies and do blood tests twice a day. And, when the standard is maybe 2 or 3 scans maximum during the cycle. So pay a little bit more attention on the stimulation, I would say. Make sure you exclude factors like DNA karyotype issues on both of you. Investigate sperm a little bit more because sperm is important as well. And sperm assessment is not just a reflection of a normal semen analysis. There's other factors as well. Discuss with the lab again. Do they do ICSI or do they do standard IVF? What sort of incubators do they use? There's a lot of kitchen secrets, laboratory secrets that any lab, I think, should be ready to openly discuss with you, the patient. So I think there's a lot of exploration to do if you're a 32-year-old. But my feeling is that you can probably produce more than 2 eggs with effective stimulation. And if you grow them to blastocysts and identify good quality blastocysts, and if you keep going, that you will be pregnant within the next 12 months.
Brilliant. Thank you so much for this encouragement indeed. And now we will go for the next question, next patient, and next case here. Next case. So I'm 30. With unexplained fertility, tried IVF 8 times. Last 4 times with PGT, I see that the number of embryos that become blastocysts is getting lower and lower. The last AMH taken was 25 picomoles in 2022. Now we have one blastocyst with PGTA result of euploid. Do you know what should be done to prove the chance in the frozen embryo transfer for that one blastocyst?
Yeah, sure. Yeah, hi Jita, thank you so much. I mean, I would definitely invest, since you have the embryo. The equation is very simple: embryo and U. Okay, so we have the embryo, so we focus on U. U are two components. One is the uterus and the neighborhood of the uterus, and the other component is the climate around you. Around your uterus and the neighborhood, which is your blood flow, your immune status, your inflammation status, and all that. So I would invest very heavily on ensuring that the endometrium is normal by doing a hysteroscopy, perhaps endometrial biopsy. I would definitely check the tubes. I mean, most people, they don't pay enough attention on the tubes. Why? Because they believe that, okay, it doesn't matter, I'm doing IVF. It does matter, in my opinion. Maybe it doesn't matter for the majority of patients, but you're not the bog standard patient after 8 failed attempts. So ideally, I would do a laparoscopy and hysteroscopy on you, to be honest, just to ensure there's no pelvic infection. Even mild endometriosis may affect implantation through inflammation and other mechanisms as well. So laparoscopy, hysteroscopy to exclude any pathology. If there's signs of infection, remove that infection. If you have endometriosis, remove the endometriosis. The chance of having endometriosis, in my opinion, could be as high as 50%. Even if nothing shows on scan, nothing shows on symptoms and all that after 8 failed implantation. So yeah, make sure you have the right environment for implantation, and the gold standard is laparoscopy and hysteroscopy. And if that's the case, then look a little bit into the immune factors. A lot of people, many people, most gynecologists perhaps, they don't really believe so much in the immune factors. I'm one of them, but that's for the standard case. For case that starts off, or you're not a standard case. So even if the chance of having an immune factor is perhaps no higher than 5 or 10%, or even less, I think it's important exploring it. Thrombophilias, look at thrombophilia effect, and of course then look at various add-ons that you may be given in the preparation protocol. The evidence, the way the evidence is created, which is fantastic. There are some amazing people all over the world creating evidence, but the evidence is fine overall. It's like the national health systems, they're fine overall. Perhaps that's not as fine for the fertility patients, if you see what I mean. So, you are a special case. I think I can't believe you're totally unexplained. I think there is a factor there that hasn't been explored. So yeah, before you implant that precious embryo, make sure you look into areas that perhaps are unlikely to be there, but even excluding them may be very positive for the way forward. And look into fortifying with discussions with your doctors, of course, into fortifying the implantation, the embryo preparation, the uterine preparation protocol before the embryo transfer, and also consider endometrial PRP. Consider that as well, whether there is something evident on the endometrium or not.
Okay, thank you so much again for this advice. Let's have a look. Next question from Karen. So 42, AMH 1 nanogram, FSH 9.9, and AFC 12, but many implantation failures. Could PRP help with egg quality? Would that make sense to try PRP, or would you advise PGT only on this case?
Hi, Karen. Look, you are blessed. I mean, you're blessed with an AFC of 12. And presumably, as long as you produce embryos, as long as you produce good quality blastocysts, I don't think that PRP would add much more. PGTA, yes, would. PGTA would probably help you avoid unnecessary embryo transfers with abnormal embryos. It would probably save you from unnecessary miscarriages of abnormal embryos. And it would most certainly give you the confidence that at least you have normal euploid embryos. There's a wonderful recent study, fascinating study this year, that showed that up until the age of 42, 43, the implantation chance of a healthy PGTA tested, a euploid, a healthy DNA healthy embryo is the same regardless of the age. So yeah, identify 1 or 2 good quality embryos and you will get pregnant, in my opinion, through PGTA. And of course, the same applies to you, in my opinion. Look into some other factors that may improve implantation. Do not forget your anatomy, ladies. I keep repeating that. I mean, IVF specialists these days are amazing, bright lads and lasses, and they're very well, trained and prepared, and they study amazing stuff. But unfortunately, they haven't been exposed to the surgical component of fertility. In my opinion, every fertility unit should have, the expertise of also anatomical assessment and anatomical, if you like, literacy of our patients. I mean, IVF is not just IVF medicine; it's also IVF surgery. I mean, in those old times, in the 90s, in the 80s, in the early 2000s, we were called specialists in fertility medicine and surgery. Do not forget surgery. Fertility is not just IVF, it's not just lab, it's not just ovarian stimulation, egg collection, embryo transfer. It's also investigation of the anatomy and perfection of the anatomy in order to receive the good quality embryo. So don't forget the anatomy. Don't forget a healthy endometrium, well-prepared endometrium, and a healthy pelvis, which is free of endometriosis and free of infection.
Okay. Once again, thank you so much. I hope that was, again, helpful. Okay, and let me show you this question. So freezing and thawing in prepared PRP samples before not sure here, is useful, or is it useful or not useful? It should be done in all type of PRP, endometrium, ovarian PRP. Anything you can add?
Well, to be honest, I don't know. I don't have an answer. I think it depends on the setup. I mean, in our setup, we use fresh. So if there's no such privilege, if there's no such, many labs, they don't work every day. They don't work Sundays. They don't work weekends, bank holidays and all that. Or they even batch patients. I mean, there are some labs that work 10 days a month or 2 weeks every 6 weeks and so forth. So it depends on the setting. In my opinion, I don't have a huge experience in PRP, but in my limited experience, practical experience, I would, if it's possible, I would use fresh. If it's not possible, frozen.
Okay. Thank you so much. There are some other questions that are a bit off topic, but I'll be happy to simply forward those questions to you and your team, Dr. Tsakos. But
2 more because...
Yes, of course. That's why I just wanted you to see, because there's a question again from Elena. So are you familiar if PRP is also available in other countries in Europe?
Hi, Elena. The question is not whether, in my opinion, it's not whether it's available, but whether it's set up. I mean, it's a service. It took us, my team and I, we've been studying theoretically for PRP 10 years. And then when we decided to press the button in producing PRP, before we decided yet whether we're going to use it or not, it took us another 6 months to set up the service. And then once we set up the service and we were happy with the production of good quality PRP and good concentration and free of infections and following quality control and all that, it took us another 6 months to decide, where to start, how to standardize the patients, the consent forms, the counseling. So setting up a PRP service is fairly more complex than it sounds. So in my opinion, the question is, are there any proper PRP centers? PRP is not just popping into a doctor's office, getting a little bit of stuff out of the blood and then, injecting it into the ovary. It's much more than that. And of course, there are some risks involved in all that. So at the moment, in my opinion, there are very few centers in Europe that do it. Yeah, very few centers.
Okay. Crystal clear. Thank you so much indeed for that. Now we will go for our final question. Okay, let's have a look at this. So what is the difference between uterine PRP and stem cell therapy? And which one would you consider more effective to help with thin lining?
Yeah, there's a huge difference. I mean, there's a difference in the substance we're injecting. I mean, stem cell is another ball game altogether. Even more controversial, maybe a little bit risky and all that. I have no experience in that. I think that, we're a little bit far from using stem cells, in a clinical practice. I mean, anyone can use it, can do it as research, as long as they follow the research guidelines of safety, quality control, data keeping, presentation, and all that, licensing, and so forth. So I think that maybe I think we have enough evidence to perform PRP in clinical practice, again, with caution, but stem cell, I think we're a little bit far off doing that.
Okay, thank you so much indeed for that. And as I mentioned, there are some questions left, but of course I will be happy to simply forward those. Helen has lots of questions, so it would take us a long time, I guess, to also answer all of them. But as always, I will forward those to the team at Embryoclinic and Dr. Tsakos, and I'm sure they will be able to help you out a bit as well. So that will be it for today. So thank you everyone for joining. It's been a great session, and thank you so much for your time as well, Dr. Tsakos. As always, it's been great to have you. Anything else? Any final words before we finish?
Sure, yeah, thank you everyone. I mean, first of all, thank you so much for the opportunity. I would like again to be cautious with regards to new techniques. I wouldn't like any of our patients, any patient anywhere in the world, to be given promises that perhaps they are not scientifically backed. PRP, like any new techniques, in my opinion, will find its place eventually in the treatment of patients with poor ovarian reserve. Until then, I would like our patients to be rational in their wishes. Yes, they are under a lot of pressure. From our point of view, as doctors, I think we're obliged to protect our patients from over expectations and from false hope. I think we'd rather be guarded than being over enthusiastic until the evidence show us the way, the indication, the method, the technique, and of course the potential outcomes that we would expect. So it's not a desperate treatment for desperate patients. I think it is a treatment that may be beneficial for a small proportion of our patients, following careful counseling, careful consultation, and of course understanding that it is only one part of the puzzle in producing good quality eggs and eventually producing good quality embryos that will implant and produce a healthy baby.
Perfect ending for sure. Thank you so much. As you can see, there are some thank yous in the chat as well. So thanks a lot for participating. And Dr. Tsakos, I know we will have some more events shortly, so looking forward to it as always. In the meantime, let me invite you for our next event that will take place tomorrow, actually. So 7 p.m. London time, and we will talk about miscarriages. So if this is something you would like to ask and find out a bit more, join us at 7 p.m. London time tomorrow. And of course, Dr. Tsakos, see you soon. Thank you so much, everyone, for joining, and enjoy your evening. Bye. Take care.
Bye.